is sponsored by United Methodist Men and produced by the production ministry of Hope United Methodist Church, Southfield, Michigan. At this time, we'd like to have a welcome from our esteemed pastor of Hope United Methodist Church, Reverend Dr. B. Kevin Smalls.
Good afternoon and welcome to Hope United Methodist Church, where we today are having an amazing panel discussion that is sponsored by our United Methodist Men on the subject of vaccinations. We are welcoming an outstanding panel that is well-informed and well-endowed with information that will help us make good choices as it relates to the matter of vaccination. We know and we have seen the horrendous effects globally, nationally, locally of the coronavirus. It is my hope today that we will even be more informed and more inspired and a little more comfortable as it relates to the subject of getting vaccinated. I thank God for you. I thank God for the work of the United Methodist Men, and I say welcome and a special welcome to our distinguished panel. Thank you very much. My name is Reverend Kevin Smalls. I'm the senior pastor here at Hope United Methodist Church, and I continue to thank God for all your work. And now we invite you to let us take a moment and open our time together with prayer. Dear God, we give you thanks for this day. We thank you for an opportunity to gather and to have conversation, enlightenment, and education around a very important subject as vaccination. And so, God, we ask that you be here with us today and give us all an extra dose of wisdom and an extra dose of your grace, that we might meet these challenges that confront us and that we might stand firm in your power and in your strength, knowing who is in charge. You are still in control, and it is in the name of your Son, Jesus our Lord, that we do pray. Bless our day, bless our time together. Amen.
Dr. Phyllis Meadows is a senior fellow at the health program at the Kresge Foundation. Her career spans nursing, public health, academics, and philanthropic sectors. We are so happy to have her as our moderator for today, and as we're leading discussions that is very important for the African American community in particular. Thank you very much for joining us today, Dr. Meadows.
Well, thank you for the introduction, and good afternoon, and welcome to our panel discussion, COVID-19 in the Black community. I want to acknowledge Pastor Smalls. I hope we do get a chance to hear from him before our session is over. I want to acknowledge him, and as well as the United Methodist Men of Hope, United Methodist Men of Hope United Methodist Church, long title, for your God-given wisdom in deciding to host today's session. As a health professional, it means quite a bit to know that the important information that you're going to share today is reaching our community. I'm delighted to serve as the moderator for today, largely because I get to enjoy, along with you, the breadth of knowledge and experience that you will hear from our distinguished panel. Proverbs 18:15 says, "The heart of the discerning acquires knowledge. The ears of the wise seek it out." So I welcome each and every one of you who took time from their precious week to join us. Our goal for the time we've allotted is to shepherd at least a modicum of knowledge to you, our virtual audience today. We hope to further your understanding of the impact of COVID in the Black community, and to shed more credible light on the issues and challenges that we've all heard in the media, and to bring you closer to the voices of those whose professional work has been based on a commitment to addressing health disparities in Black communities. We suspect that many of you are wondering and deliberating how to manage during this pandemic, whether to be vaccinated or not, whether to gather, and how to do so safely. We hope that you'll use this time to learn and to ask questions, and hopefully dispel some of the myths that are permeating in our community and seek the truth from these very highly credible panelists. by engaging in a fruitful discussion. So please prepare your questions. You will hear from 3 speakers today, each for about 10 minutes. Collectively, they've prepared presentations to build your understanding about COVID-19. You will hear data to help you understand how the community is faring in the context of the pandemic and to learn more about the vaccine. I received my 2nd dose last week. We will be moving fluidly, so as questions arise, please feel free to place them in the Q&A box. And we've reserved ample time after all of the panelists have spoken for an open discussion and to address your questions. Also, throughout the session, we plan to engage you. We want to hear from you. And we have a series of polling questions just to get a sense of what you're experiencing related to the pandemic and just to hear your thoughts. So to get us started, we have our first question. Do you plan on getting a COVID-19 vaccine? Did we get any responses? Okay, here we go. Wow. So 94% of you are planning to get the vaccine. That's great news. And there are a number of you who are still deliberating. And hopefully today, after the completion of our sessions, you'll have better answers to help you move to a different category, I should say. All right. So with that, I'm going to introduce our first speaker for today, Dr. M. Roy Wilson, who became the president of Wayne State University in 2013. Dr. Wilson's previous leadership positions have included a deputy director for strategic scientific planning and program coordination at the National Institute on Minority Health and Health Disparities, which is a part of the National Institutes of Health. Dr. Wilson has served as a dean of the School of Medicine at Creighton University, president of Texas Tech University Health Sciences Center, and chancellor of the University of Colorado, Denver, Anschutz Medical Center. As an ophthalmologist and epidemiologist, his research has focused on glaucoma and blindness in populations from the Caribbean to West Africa. In 2003, President Wilson was elected to the National Academy of Medicine, Institute of Medicine, one of the highest honors in the field of medicine. He received his undergraduate degree from Allegheny College, an MS in epidemiology from UCLA, and an MD from Harvard Medical School. Please join me virtually in welcoming Dr. M. Roy Wilson.
Well, thank you very much, Dr. Meadows, and I want to thank Hope also for this invitation. I've been asked to talk about both health disparities and vaccinations from a historical perspective in 10 minutes. So that's going to be quite ambitious. If I can get the first slide up, I do want to just focus on a few main concepts because time is limited. First, under health disparities, we'll discuss a little bit about implicit bias, the fact that place matters, where you live, where you work, where you pray, where you play makes a big difference. And then I'll make a mention about the coronavirus racial disparity task force that the governor put together that I was fortunate to be on. In terms of vaccinations, people sometimes are very confused because of the different terminology used. Coronaviruses as a group is just a group of related viruses that cause diseases in mammals and birds. In humans, they can cause respiratory tract infections, and these infections can range from really mild to lethal. For example, the common cold, about 15% are caused by coronaviruses. Most is caused by another virus called rhinoviruses. But you've heard about SARS and you've probably heard about MERS. SARS is severe acute respiratory syndrome. Well, that's also from a coronavirus. Some people will call it SARS-CoV-1. And that was first detected in 2002. And then MERS is the Middle Eastern Respiratory Syndrome. And that was detected in 2012. So that's MERS-CoV or MERS coronavirus. And then obviously we're dealing now with the SARS-CoV-2, a novel coronavirus. It's a new one. And that's the virus that causes COVID-19. And that was detected roughly in the early part of 2020. So one of the things that you'll notice here, and this is true of other viruses too, is that there's a periodicity here. You know, about every 8 to 10 years, there seems to be a new one coming on that is infecting humans. And so many epidemiologists are concerned that if we don't get our public health infrastructure straightened out this time, that the next pandemic could be even worse. And so we have a lot of work to do. You know, the other thing I just wanted to mention is that the difference between SARS and MERS with respect to and COVID-19 is that you really didn't have a lot of cases of either SARS or MERS, but of those cases that did occur, it was much more severe. It's really pretty rare to see SARS or MERS that was asymptomatic or mildly symptomatic. Most of the people were pretty sick. With in MERS, there was only about 2,500 cases worldwide, but out of that, about 850 deaths. So, you know, a large percentage, about 35% of those who contracted MERS died. And then we're going to talk a little bit about how vaccines work. Maybe we can go to the next slide, please. This is a slide, this next slide is a slide that I like to use a lot. It's a woman, a Black woman sitting on a doctor's desk, a chair, I mean, and saying, "Give it to me straight, doc, I can take it, what's wrong with me?" And the doc says, "You're not a white male." This was taken from a study that was done a while back now, but it's really a landmark study. It's a study by a guy named Schumer, and it was on cardiovascular disease. And what he did was he had actors who simulated patients. They were all dressed a certain way, they spoke a certain way, and they all had identical symptoms. And these actors were presented to family doctors and given these symptoms. The correct diagnosis or correct intervention based on the symptoms was to be referred for cardiac stent. Well, it depended on whether you were Black or white or male or female, whether you got the right intervention. Women were not referred as much as men, and Blacks were not referred as much as whites. And so if you were a Black woman, you really had a double whammo. You weren't referred as much as men, and because you're Black, you weren't referred as much as white. And so this study has been repeated many times now in different populations, and it's really pretty much the same thing, that there really does exist an implicit bias in medical care. And how it played out, for example, with COVID-19, is that you might recall in the early days, emergency visits by people who thought they had the disease, and anecdotal reports of Blacks particularly being sent home. Well, a lot of that was because of implicit bias. For example, in the early days, there was a lot of questions being in the emergency room as to whether or not you had foreign travel, because it was a risk factor if you had traveled in foreign lands. Well, you know, how many Blacks do you know is going to the French Riviera on a yearly basis? But questions related to living arrangements. You know, how many people live in the house? Can you socially distance? If somebody has COVID-19, is it likely that you'll be able to stay away from that person? Those kind of questions weren't asked. Well, that is an example of implicit bias. And then if we can go to the next slide. This is a slide, I'm sure you're will recognize this airplane. This is a plane that was landed on the Hudson River by Captain Sullenberger. And the thing I want you to notice is all these people in the middle part of the plane, on the wing there. You know, the water is up to their ankles. I see no life raft anywhere. They're bunched together. The water is freezing cold, and you know, you can't see their faces, but I can imagine they're very worried. Then you look at the front part of the plane, and you see a different situation. You know, none of these people are actually in the water. You see life rafts, and you see that they're pretty spaced out. Well, obviously, those that's in the front of the plane are in first class, and those in the back were in coach. But this is an example of how place matters. Where you sit on that plane will determine what access you have to survival. And this is a very vivid example, I think, of how place makes a difference in terms of determining what social determinants of health one is exposed to. And with the COVID-19 infection, you know, how this played out, of course, is what type of job you had, whether you could work remotely from home, or you had to come in because you drove a bus. The size of your house, whether or not you had separate bedrooms to be able to isolate if you thought that you might have been exposed, or someone else in your household has been exposed, versus if you have multiple families, you know, living in a single home. Proximity to testing centers is another a determinant. You know, in the early days of the pandemic, testing centers were put in places that were basically in the suburbs. That was very difficult to get to. And that's why Wayne State, we created these mobile testing units and went out into the different populations. But that's an example of how place matters. Where you live and where you work and where you play and where you pray makes a big difference in terms of the social determinants of our health. You know, final comments related to health disparity. I did mention the governor's coronavirus task force on racial disparity. I mentioned that because I do think that they did a great job. And I'm not saying it because, you know, I was on it, but really the racial disparity in COVID-19, both cases and deaths, really was, for new cases, was eliminated by around mid-June. And then all during the fall, this racial disparity for new cases was no longer prevalent. And certainly this has been recognized nationally, and the task force is actually going to get a very huge national award by Research America next month in recognition of the work that was done to eliminate, or at least drastically reduce, the racial disparities that were seen in the early phases of the pandemic. The reason why this is important to me is that it gives hope for elimination of racial health disparities on a broader scale. You think about it, you know, racial disparities, health disparities was first introduced really in around 1985 with Margaret Heckler. She was the Secretary of Health and Human Services under Reagan. She had a task force that reported on minority health and showed that there were 80,000 excess deaths among minority, basically Black populations, that wouldn't have occurred if the rate of disease in those populations were the same as in white populations. And but there really hasn't been a whole lot of progress since then. And so to look at something like what's happened with, at least locally, with racial disparity with the COVID-19 offers some level of hope that that there could be some solutions more generally. I am very concerned that with the increased numbers of COVID cases in all populations and all racial populations more recently in Michigan, then we're going to start possibly seeing this racial disparity again. Although right now it's holding pretty steady, but I do think that that's something we have to watch out for. Let's go on to the next slide real quick. I don't have a whole lot more time, so I do want to just get to the vaccine and just show you that there's something called spike proteins. I'm sure you've heard of those. Those are proteins that are on the surface of the SARS-CoV-2 virus. And what happens is that these spike proteins bind to receptors that are on the cell surface, in this case on respiratory tract within one's body. And when it binds, the cell kind of dents in and envelops the virus, and the virus goes into the cell, and that's how the infection is initiated. Now there are antibodies, and you can see that blue Y-shaped substance there, which can bind to the spike protein, and that will prevent it from going into the cell. If we go to the next slide, what you see is another graphic depiction. So way over to the left-hand side, you see the receptor on the cell, and then the next cartoon there shows how infection occurs when these spike proteins bind to the receptor. And the third cartoon there shows that this can be blocked by an antibody. That's the purple round things that's supposed to be the antibodies. And then on the last cartoon there, you can see that the antibodies had coated all of the spike proteins. So now there's no chance of that particular virus going into the cell and initiating the infection process. I just want one final slide is that, obviously these are schematics, but this is what the actual COVID-2 virus looks like. As a Wayne State student well, someone who was a Wayne State student is the one who came up with this three-dimensional atomic structure. And it's also a great example of how the vaccine was able to be developed so quickly. People sometimes are concerned because it was developed so quickly. Well, there was a lot of foundational work that was being done. And in this case, the Jason McClellan, who was the Wayne State student, had been working for years on developing these three-dimensional atomic structures of other coronavirus viruses. And he had been mapping these structures and had worked out all the techniques of doing that. And then when the genetic sequence for the SARS-CoV-2 came out, within 2 weeks, his lab was able to map out the structure of this spike protein, the CoV-2 atomic structure. And as I showed you in the previous slide, that's absolutely key to being able to develop the vaccine that fits onto these spike proteins. You have to know what the structure of the spike protein is in order to develop the vaccine that can fit into it. And so that was done in 2 weeks, which took years of previous more foundational work developing the techniques of how to do this. So that gives you an example of some of the foundational research work that allowed the rapid development of the vaccine for COVID-2. I'll stop there. I think I went maybe a minute or two over, but I apologize if I did. Thank you.
Thank you, Dr. Wilson. We appreciated every minute or two that you may have gone. There are a couple of questions that did pop up, and I know we're a little off script here, but maybe we can begin to answer those because they're directly related to your presentation, Dr. Wilson, if you don't mind. And one question comes from Gina Walker, who asks, can ACE2 blockers help? You're on mute, Dr. Wilson. You're still on mute, Dr. Wilson.
I'm sorry. So the question had to do with, will ACE2 blockers help?
Yeah.
Okay. The receptor that's on the cell surface are ACE2 basically, and so yeah, there you are, the ACE2 receptor. And so basically, what the vaccines are blockers of these ACE2 receptors. If you're talking about common medications that are thought to be ACE2 receptors, they're not going to be specific enough to be as effective as one that is built specifically for the particular viral infection.
Thank you for that. So what we're going to do is we have a couple of polling questions that we want to ask, and if we can take a look at those, if we can get question number 2 from our host. Have you received the vaccine yet? You'll let us know. And I think from that first question, it was at least 94% of the folks had planned to get it. So now we're wondering if, in fact, there are those of you who have received it yet. And maybe we can see the results. Okay. Well, we have 66% of the folks who've received 2 doses, 11% at 1 dose, and there are some who haven't received 23%. That's pretty good. I mean, I think if the goal is to be vaccinated, I think a number of you are moving in that direction. But I think you also have some questions, and we hope to get to those shortly. So stay tuned. Those barriers are. Where we're going to go now is a little bit off script. I'd like to introduce our what would have been our 3rd speaker, but I think given the body of questions that are emerging around vaccines, it's probably appropriate at this point. Dr. Robinson, I know we're catching you a little off pace here, but I'd like to introduce Dr. Derek J. Robinson, who is an emergency medicine specialist and a physician executive, who's going to be our next speaker. Dr. Robinson is a highly regarded physician executive who is board certified in emergency medicine. He has broad healthcare, health policy, and leadership experiences and used those during this pandemic. He's been called upon to support public education efforts at the local and national levels on COVID-19. Dr. Robinson earned degrees from Xavier University, Howard University College of Medicine, and the University of Chicago Booth School of Business. He's frequently invited as a speaker to provide perspective and expertise on current issues related to health equity, social determinants of health, implicit bias, and the imperative for physician diversity in the workplace. Most recently, he served as a keynote speaker for the National Institute of Healthcare Management, the National Hispanic Medical Association, the Mayo Clinic, and Loyola University. Pardon me. Dr. Robinson has also served as a panelist for the National Medical Association, the National Minority Quality Forum, University of Southern California Race and Equity Center, Common Threads, and the McCormick Theological Seminary. So please join me in welcoming Dr. Robinson to the virtual stage.
Dr. Meadows, thank you so much, and good morning to everyone, or good afternoon, depending on what time zone you're in. It's indeed a pleasure to be with you. To our tech support, I'm working to turn my video on, so if you can toggle that on, would be great. So this morning I was asked to join you all to talk about why it's important to get vaccinated. And I thought what I would do here is just take some time to have a conversation with you. I don't have any slides that I'm going to present, so we can pull that down if you'd like. And since Dr. Verholden hasn't had a chance to join us yet, I may also cover some broad statistics that would, I think, match up nicely against a really excellent presentation and content that Dr. Wilson has shared with us so far. So we know that across the nation, we've had 202 million vaccinations administered, and that is remarkable given where we found ourselves sitting at even 6 months ago. You just think about the climate of our nation and where we are. We know that the vaccinations were prioritized for our elderly and most vulnerable populations, and so we see the highest rates of vaccination today in those age groups. We know that 65% of individuals that are 65 years of age and older have been fully vaccinated. And so we're great to continue to see us moving in that direction. And about 1 in 4 Americans in general have been fully vaccinated as well. And it's remarkable looking at this call that we've got 94% of folks that they're either vaccinated or they're going to get vaccinated, and a significant amount of folks who are well on that journey, with 66% vaccinated in this group. I want to talk a little bit about, excuse me, why we should get vaccinated. I think this can help with some of the discussions that many of you will have with individuals in your community, in your family, and in your workplace. It's startling to think that we've had so many people who have died, but that is the reality. We've had 562,000 individuals in the United States who've passed away from COVID. Even healthcare professionals like myself have had friends, colleagues, and family members who have succumbed to the illness from COVID-19. And we know that most individuals who contract COVID will do okay. We also know that individuals that have one of many chronic medical conditions cannot have as good of an outcome. And some of those conditions might include obesity, diabetes, cardiovascular disease, hypertension, chronic kidney disease, for example. And when we look in our community, individuals usually don't have just one of those. A lot of times we'll have what some might refer to as a package. So we might have a little bit of sugar, a little bit of blood pressure, a little bit of obesity, and a little bit of kidney disease. And then, oh, by the way, happen to work as an essential worker or a frontline worker, where we have high exposure or contact to other individuals in the public, which makes our risk of exposure to the virus higher. So in many instances, we have higher risk of exposure, and then we also have chronic medical conditions that make our odds of surviving a clinical course with this condition not as favorable. And then you can layer on top of that some of the social components, where we have more multi-generational households. So you have people at different age groups with also different levels of exposure in the community, and we might be more likely to use public transportation. So the risk profile, the level of exposure, the odds of survival are different in our community, and that's something that really should factor into consideration regarding getting vaccinated. And we look across the nation, we know that Hispanics and Latinos had the highest hospitalization rates. We know that Native Americans have had the highest death rates, but we also know that the quantity of deaths across the United States have been highest in the African American community. So why should you get vaccinated? Number one, we don't have a cure. So as physicians, nurses, respiratory therapists, healthcare workers, we have figured out some ways to better care for patients who are suffering with COVID infection than we knew a year ago. But we don't have a cure. There's not something that we can give you that makes the viral infection go away. As we deal with some of the variants that are coming about, we're seeing some changes in how some therapies are effective, some being a little bit less effective, some of the monoclonal antibody therapies against some of the variants like the Brazilian and the South African variant. So getting vaccinated is one of the most important and strongest ways that you can help prevent COVID-19 infection and transmission. We certainly know that you have to also continue, good hand hygiene, social distancing, and wear a mask are also effective ways to do so. We want to get vaccinated so that you can help protect your own health and protect the health of your family members, those elders in our community who, even as you think now, some of you may have questions about, your family history and background. Those elders have that, but as more and more people are getting sick from COVID, we begin to lose some of that history. So you want to protect those that are in your family as well. We also have members in our community who are vulnerable. They may have unique medical conditions that make getting vaccinated not an option for them. So they're counting on all of us to do our collective jobs and be responsible citizens and getting vaccinated. It's also critical to helping our economy recover. And that means getting individuals back to work, getting our businesses open, getting our students back to school, and getting to that herd immunity level and reducing the amount of infections circulating in the community is critically important. But I think also the experience that we're seeing in Michigan right now, which mirrors what we saw in Southern California in December and January, is a stark reminder that we simply don't have enough hospital beds and ICU beds to care for every single individual that might get severely ill with COVID. Remember, we talked a lot about flattening the curve last summer, keeping in mind that we had this sort of line of capacity. There's a lot of work to raise that capacity level, but as infections go up, that curve can exceed the capacity level that we have to care for individuals. So what we've been trying to do is flatten the curve, and part of the efforts to do that can be greatly assisted by individuals getting vaccinated. And the last thing that I'll say on this particular area is that, you have the option of getting vaccinated or not. I think the option of not getting vaccinated is a very high stakes proposition. Again, we've got high levels of chronic medical conditions, high levels of exposure to the virus in our communities, a lot of challenges in terms of the social determinants of health. And we know that the vaccines that we have, which are authorized and on the market today, are highly effective and safe with millions and millions of individuals who have been vaccinated. So I would strongly encourage individuals to take in the information that is available, talk to your trusted medical professionals. Keep in mind that those of us who are on this call, especially for those who have concerns regarding some of the historical discrimination that minorities have faced in the healthcare system, please know that as seasoned professionals, we are well aware of both that historical context and some contemporary context. What we are able to do is separate out those instances from what it is that we are dealing with acutely with COVID-19 and the vaccines available, and to be able to distinguish between the two. So the experience that we are going through with this effort to get our communities vaccinated today is not the same as what we've seen with past issues with the Tuskegee experiment, for example, the treatment of Henrietta Lacks, and many other examples of mistreatment in the African-American community, which has earned significant distrust within our community of the healthcare system. So we acknowledge that those are real concerns, valid concerns, but we also want to ensure that we're providing good, solid information to help our communities make the right decision during such a very important time. So Dr. Meadows, thank you so much for this opportunity to contribute to the discussion. Be happy to support any questions at this time or later in the discussion.
Yes, thank you, Dr. Robinson. Very, very helpful and insightful presentation. There are a few questions. As a matter of fact, there are quite a few questions that are emerging around the vaccine. And one in particular that I think a lot of people are asking, is it true that even with the vaccination, one can still contract and infect others?
So, from reading the trial data, as well as looking at what some of the real life experiences with the deployment of the vaccine, has shown that there is some risk of getting infected after getting the vaccine, but those risks are very low. And the best way to, I think, to describe this is that we don't have anything that is 100%. Even when the numbers say 100%, that means it's close, but it's not perfect. And so part of what we've got to do is ensure that individuals are protected, but also ensure that we are suppressing the level of infection in the community so that there's less virus circulating. As a physician, I was vaccinated in December of last year with my first shot and January with my second shot. But I've continued to wear a mask even as I've moved around the community. And actually for a while, I've worn 2 masks. And I've also encouraged members of my family, including my parents who were of that elderly age range, to be vaccinated, to continue to do the same and use caution. We want to use good common sense to ensure that, again, we continue to maximize our ability to be protected while we're still living through a pandemic.
Thank you. I'm going to ask you another question because there
Sure.
are quite a few around vaccinations right now, but this is one that I'm sure won't be a surprise to you. What specific messaging do you have for the segment of the Black community adamant about receiving the COVID-19 vaccine, given the history of Black men and people being used for lab testing? The best message there?
Sure. So it sounds like the question is adamant against getting the vaccine. What I would say is that this is not the same. Being concerned is reasonable. Having a healthy skepticism is reasonable as well. But we also have to get all the information in so that we can then make a good decision going forward. So I want to be very careful not to be dismissive of those concerns. But then I want to acknowledge also that we have a different structure in place for monitoring how trials are done. We've got significant diversity involved in this particular COVID-19 vaccine development process. We also have a lot of transparency in terms of the ability to look at the data, see which populations it was tested in, see what the effectiveness of the vaccine was in various racial, ethnic, age bands, and condition categories, so that we have good information to use as we go forward. So this is a distinctly different opportunity than the experiences that are reflected in the question. So that would be my message to them. And you've got credible individuals like Dr. Wilson, like myself and others who are very engaged in this process. And then the last thing I would notice, it's one thing to listen to what people say, and another is to watch what they do. And so I'm not just saying get vaccinated, but as a Black man who fits in the category of individuals who had the greatest life expectancy loss in the United States in the first 6 months of last year, primarily due to COVID, that I got vaccinated. And I think it's extremely important that folks in our community consider being vaccinated for the reasons discussed earlier.
Thank you, Dr. Robinson. I'm going to chime in on Dr. Wilson to see if he has some thoughts around messaging. What can we say to those? And I think part of the question was, there are a lot of folks who are pushing get vaccinated, get vaccination in light of that history. So are there things that we need to, beyond the wonderful things that you've suggested, Dr. Robinson? I was going to ask Dr. Wilson, did he have any thoughts about that?
First of all, I think that Dr. Robinson answered the question excellently. I'll just add two things that might add a little bit of color to this. One is that, one of the reasons why people have been hesitant is because they say that it was just developed too soon. And I mentioned once, something about the foundational science and the fact that there's a lot of work that was done before. The one thing that a lot of people don't know is that there was a vaccine that had been developed for the MERS COVID. And the reason why it wasn't produced, even though the work had been done to develop it, is there wasn't a market for it. As I mentioned, there's only like 2,500 people who got it, worldwide. And so the pharmaceutical companies didn't want to invest the amount of money that they would have had to invest in order to make it worth their while to have produced a vaccine. But there actually was one already developed. And so to then develop the SARS-CoV-2 vaccine, you just had to use what was already all the work that was done for the MERS and just tweak it a little bit in order to come up with that vaccine. So that's one thing. The other thing that is important to know is that one of the lead vaccine researchers is an African-American woman, Kizzy, who I happen to know from my time at the NIH. And she's the head vaccine person at the National Vaccine Center of the NIH. And so you should have some comfort that you at least have a sister in there that's watching over things and is a lead researcher for the vaccine development for NIH.
Can I add just one comment to what Dr. Wilson stimulated my mind? I think the other thing that we should also just acknowledge is that there was so much, sort of misinformation and disinformation floating around across 2020 that I think it has really created a confusing effect for folks, despite these remarkable advancements that were made in the production timeline for the vaccine. So that's, one elephant in the room that we don't want to ignore. But certainly, I think the information and background that we're providing certainly supports making a good decision. And I think it underscores why we have to be present and involved in these discussions, because we're still having to work against not just the historical distrust, but also a lot of the confusion that was created over the last year.
Thank you. Great. Thank you both. We'll be able to do more questions and answers later on. We are very lucky now to have Dr. Verholden join us. Let me do a quick introduction. Dr. Verholden is a Johns Hopkins trained epidemiologist, a health equity researcher, and public health activist. She has published more than 100 peer-reviewed publications in some of the nation's leading journals, including a recent seminal publication in Addiction, calling out racial inequity in the response to the opioid crisis. Recent media includes an on-air interview with MSNBC Live with Stephanie Rule, an expert input in quotes in COVID equity in USA Today, Politico, the New York Times, and an op-ed in The Conversation. She is actively working with former Ohio State Senator and congressional candidate Nina Turner to disseminate an open letter to the Biden-Harris administration to mandate equity in COVID vaccine distribution and administration. And those of you who don't know Deborah, she's definitely worth waiting for. I'm glad she's able to join us, and we'll let you take it from there. Dr. Verholden.
I'm a data person. That's my training. That's my background. I think knowledge is power. So, I was raised that way. It's no surprise that I became an epidemiologist, and we are basically professional evidence collectors. When I look at what the data are telling us, there's a couple of things that are very telling about what the data tells us and what the lack of data tells us. Number one, I want to make sure that all Michiganders understand that Michigan has done a much better job compared to other jurisdictions and other states of collecting data. We were one of the first 3 states to transparently report racial disparities in COVID cases and deaths. It all happened in the same 48-hour period. Michigan, Chicago, Illinois, and Louisiana all were forthcoming with those disparities. And Michigan is the only state that I know of to date that has any evidence of closing the racial disparities gap in COVID cases and deaths. And even as I look at this recent surge in cases, and I'm not pretending as if we don't have a problem, because we do, but I'd like for us to take a look at what that problem is and what we can do and what we should be imploring others in positions of power and authority to do to turn the tides on these disparities and on this recent surge. We are very good at COVID testing. If you look at COVID testing all across the nation, Michigan is one of the highest ranked states on COVID testing. And even as our numbers started to go down, what we didn't do is have testing go down. So it's important that people understand COVID cases are only a function of COVID testing. If you had every single symptom of COVID and you called your local health department and you said, I've got fever, chills, headache, body aches, fatigue, I've lost my sense of taste and smell, nobody puts a hatch mark in a column somewhere and you get counted. You only get counted as a COVID case if you actually get a COVID test. Michigan does very good at community-wide, system-wide COVID testing relative to a lot of other states. So I think a part of what we're seeing in Michigan is simply due to the fact that we just do a better job of identifying cases. And we also have been transparent about reporting out on those cases. The other thing is that we are, and people have seen this in the media, we have the highest number of any state in the US of variant cases. And what people don't realize is the vaccine is an imperfect but very important layer of protection in the fight against COVID. But it is not a panacea. No one thing is going to solve all of these problems. And if you go back to the real height of the epidemic, early on last summer, and then that sort of second surge that we saw late fall, early winter, what we noticed is that we were able to flatten the curve in Michigan in the absence of a vaccine. How did we do that? We did that with public health and prevention. And it was a shared combination of personal and shared and governmental responsibility. We had people really honoring protocols, wearing a mask, washing their hands, watching their distance, keeping that physical distance, social distancing aspect of this pandemic mitigation response in effect. And we also had substantial governmental support. We had enhanced unemployment, right? That actually provided people with a living wage who had lost their job or were unemployed or underemployed due to COVID, or maybe not due to COVID. Because the shelter in place order fell on deaf ears for many. Shelter in place was not something that a lot of people could honor if you had the kind of high demand, low wage job where you didn't have the income from that job that would allow you to keep your lights on during the pandemic. So we had lots of things that were happening all at the same time. And even in the absence of a vaccine, all of those things happening at the same time allowed us to flatten the curve, to bring that case curve down and then get it leveled off. In the county where I live, in Genesee County, and Flint is the county seat for Genesee County, and I live literally smack dab in the center of Flint. 7 weeks ago, our community case rate was 2.9%. That 2.9% happened. Those were not vaccine related results. That was the impact of the hope was coming, the vaccine was coming. So people really tightened up because we were all hopeful that the vaccine would give us that extra boost and added layer of protection. But I think, again, for a lot of people, it created false hope. A lot of people got vaccines and then started to immediately resume life as normal. Schools open, restaurants reopened, churches have started to re-engage in-person worship services. All of those other important layers of protection that we had in place, we are either don't have them or people aren't honoring them. And what I would offer people is adding this extra layer called the vaccine will do something tremendous for us in this pandemic mitigation response and will help us, but not if we undo or take away all of the layers of protection that we had before that. So I do have a little quick graphic that I want to show, and then I'll pause and get back into the conversation. I had a whole PowerPoint, but since I don't know what's already been talked about, I just want to share this one thing with you, because the model and the thinking is called multiple layers improve success. And I really fundamentally believe in this model. And I think it's something that I really want all of us to not only just consider, but think about what does it mean in my own personal life, and also what does it mean in the lives of the people in my community. This is what's called the Swiss cheese respiratory pandemic, virus pandemic defense. And think of it as Swiss cheese. Think of these little green molecules as the coronavirus. You'll notice they can get through the Swiss cheese, but the holes don't run all the way through. What each one of these layers represent are different layers of responsibility, including personal responsibility. So practicing the physical distance, staying at home if you're sick, wearing your mask over your mouth and your nose, washing your hands, covering your cough and your sneeze, avoiding touching your face. We've all heard about keep your hands out of your face, and I think we've all become much more hyper vigilant about that. And things like avoiding crowds and unmasked groups. But then again, there's this whole world of shared responsibilities, access to fast and sensitive contact tracing and COVID testing. Things like indoor ventilation and air filtration, always remembering that outdoors is best. Government and financial support and regulations and messaging. We saw Johnson & Johnson is being paused. We need those important things. Support so people can actually quarantine and isolate when needed. And then this very important last layer, access to vaccines and therapeutics. And you'll notice what we call the misinformation mouse has jumped in, and he's nibbling away at the piece of cheese. Misinformation is a real threat for us during this time period. You know, misinformation eats away at the importance and the value of these different layers of protection. We all heard the data, and we saw the report that said the largest vaccine hesitancy group right now are Republican males. Why? Because we've politicized, unfortunately, a public health crisis. And unfortunately, something as simple as wearing a mask, or even worse, not wearing a mask, has become a political statement, and for many, an act of political will or political freedom. And so I don't want to let misinformation eat away at or erode the importance of these layers of protection. And the vaccine being the most recent layer, that last layer of defense, an imperfect but important layer of protection. I just think it's important that we continue to have forums like these where people can legitimately ask questions, get all of those questions answered, and we can really do the work to give individuals what they need to understand how to stay safe during this pandemic, but also figure out what is the real governmental and shared world of responsibilities that we could all be advocating for. Because the thing that I do know and fundamentally believe, it's a great African proverb. It says, if you want to go far, you go. If you want to go fast, you go alone. But if you want to go far, you got to go together. And this is something that we're going to have to go together on. So while I agree with our governor's messaging around elevating the role of personal responsibility, it also needs to be happening simultaneously in the world of shared responsibility. And what I'm pushing for are mandates for equity, and not just COVID, but in health and racial equity in general. And what that would look like is all of these layers of protection, not just the vaccine, but also government financial support, also support for people to quarantine and self-isolate, enforcement of the laws that we do have. We have a mask mandate in the state of Michigan that has no enforcement behind it. So many of us know when you go out in the world, you will see many people who are unmasked. Laws without enforcement are akin to gums without teeth. So I think we need to talk about how do we get all of these multiple layers of protection to be happening at the same time so we can truly bring that curve down, stop the spread of virus, practice good public health, which is anchored and rooted in prevention. Good public health is about preventing people from getting sick in the first place. We don't want to get to herd immunity or community immunity by a lot of people getting sick, some people dying, and some people living with long-term effects from COVID and then recovering, and then adding that to the vaccination effort. We need and want to do all that we can to stop people from getting sick in the first place. I'm going to pause there. I'll stop sharing, and then I'll jump back in and join the conversation. And thanks for having me.
Thank you, Dr. Verholden. Wonderful presentation and wonderful reminder that this pandemic and addressing it starts with us and the decisions we make every day, not only as individuals, but as a community. So let's get to this bulk of questions that we have, and we have tons. And I'm going to ask our three panelists, maybe I'll just kind of point to you, and if you feel compelled to jump in, but I'll tell you, we've got a lot of questions, so we may go one at a time. But Deborah, since you were our last speaker, there's a question about Michigan and the fact that we've been leading in COVID cases. What can we do to bring the numbers down? And how can we better educate our family and friends on getting vaccinated, those who might have some hesitance?
Yeah, so there's a couple of things. We've talked a lot about vaccine hesitancy. And I personally understand that hesitancy is something that we'll have to deal with. But I want to dispel a couple of myths. Number one, African Americans in general are not vaccine hesitant. We just simply are not. If you go to the CDC website, or if you just simply Google vaccination rates by race, it'll take you to the CDC website, and it will show you African American parents vaccinate their children at the exact same identical rates for every vaccine that white parents vaccinate their children. If you look at adult vaccination rates, you might find for a few vaccines, whether it be tetanus or flu, a slightly lower rate among African Americans, but we understand that most of that is not actually due to a resistance to getting the vaccine. It's related to other factors like people not being able to get the time off from work, people not having health care at the time when the vaccination is available, or having other barriers to actually getting those shots in arms. But there is no other data that suggests before this pandemic that African Americans had excess vaccine hesitancy. I think the COVID vaccine hesitancy that we saw early on and with some of the earlier polls were not actually due to things like, general vaccine hesitancy, but were due to just real missteps in how this thing got rolled out. We call this vaccine initiative Operation Warp Speed. And when I heard warp speed, I heard what a lot of other people heard, which was skip steps, missteps, maybe some corner cutting. We didn't talk about the FDA approval process. We didn't spend a lot of time talking about a data safety and monitoring board, which is an independent panel of scientists who have no dog in the fight other than to make sure that whatever is going to be rolled out into the public is safe and credible and valid and has been vetted, we didn't talk a lot about that. We heard emergency use authorization. It was more of the same. It was more quick and dirty, get it out, push it into people's arms. So I think that hesitancy that we saw early on, I don't think it was a Black thing. I think it was just we don't understand. We've never seen a vaccine be developed this early. Most of us had not heard the term mRNA since biology in middle school or high school. And so I think there was a lot that we could have done different, which is now why the role of the trusted and credible messenger is so important, because there are people like myself and Dr. Robinson and Dr. Wilson who want nothing more than to be credible, trusted messengers and help answer people's questions and help to remedy some of their concerns. What I think the reality of it is that Michigan needs to do is we need to acknowledge political meddling and bipartisan politics are clobbering public health over the head. We're in the midst of a public health crisis. Politics have no business in the middle of this. And unfortunately, we've had a lot of political meddling and politics winning the day when public health should lead the day. And I think we have a great governor. Michigan has had many great governors even before Gretchen Whitmer. The problem is our governor does not have unilateral power to make all the rules and run our state. Her executive privileges to extend the state of emergency would require state legislature approval. And the state legislature has sent a clear and resounding message. They are not going to give her unilateral privileges to do that. That means we all now have to come together and set politics to the side and make decisions that are informed by good public health and the overall well-being of our residents in the state of Michigan. And I just think that that is a weak muscle for us. We've not been forced to do that. So we have to come together, and we've got to put all of those other important layers of protections back in place and let the vaccine be the game changer, but not the game maker.
Thank you, Dr. Verholden. Dr. Wilson, there's a question about I'll put these two together. Can a combination of vitamin D, vitamin C, and zinc help ward off COVID-19 or make symptoms less severe? And then I'll just add this one, and after being vaccinated, can I have a glass of wine or do I have to wait?
I think the last one first, because I drink wine every night and I didn't wait, so I hope not. In terms of the first one, there's a lot of speculation out there that's not been shown in any rigorous manner from a clinical trial. I think there are some hypothetical or theoretical reasons to believe that zinc might be helpful. I'm not aware of, and some other vitamins, I'm not aware of any strenuous clinical trials that have definitively shown that to be the case. There may be others on the panel who's aware of more recent data that I'm not aware of, but there certainly are theoretical reasons why that could be helpful, but I'm not aware of any real data.
Dr. Robinson, you're up. So a couple of questions about the vaccine. Are the booster shots a part of any COVID-19 vaccination plan from any of the current suppliers? And will the vaccine be required yearly? What do you think? Now I'll let Dr. Robinson and Dr. Wilson, if you want to add to that.
So those are great questions. And Dr. Meadows asked me, what did I think? Which is important, right? I've tried to consistently say that we have to be humble as we're dealing with COVID-19. We're continuing to learn. And so we've had, these vaccines that have been in the real world, let's say for less than a year, right? We had trials that were running last summer. And so there are some evaluations, looking back at individuals that participated in the trial and that were vaccinated early to see what their sort of persistent immunity has been. And so that information is going to inform what our path forward is like. We are hearing from some of the vaccine manufacturers. I believe we heard from the chief executive at Pfizer within the last week that they're anticipating future boosters, maybe building in some of the variants into that booster shot design and predicting that maybe this may be an annual process. I think the truth is we don't exactly know But I think we want to remain flexible as we look towards the future. We know that we have a solid platform that's allowed us to move pretty quickly in terms of deploying a vaccine. And I expect that as we move forward, either in dealing with COVID-19 or as Dr. Wilson talked earlier about, what the next potential, virus is that impacts us at some future period of time, that we'll be able to respond quicker as well. So I think the jury is out, but probably more likely than not. Dr. Wilson, any thoughts you have?
No, I think you answered it outstandingly. I have nothing to add. I agree with everything you said.
Okay, so I'll throw this one out to any of the panelists. And this is, I think, a very important one. It's related to pregnancy and the vaccine. Is there any information on how the vaccine is affecting those that are pregnant or planning to start a family or child development? Well, is there any impacts that we know thus far?
I could offer something here because this is something that hits very close to home for me. My oldest daughter is 21 weeks pregnant. So we had to have a very real conversation about what our choices were going to be. I think there are multiple trusted and credible messengers during this season. And I really am encouraging people to lean on professional societies during this time. The American College of Obstetricians and Gynecologists, that is their wheelhouse, is women who are pregnant or plan on becoming pregnant and dealing with the reproductive health of women. They've rolled up their sleeves. They've looked at a lot of the FDA data. There are many, many pregnant women and many women who were pregnant and have given birth, women who were planning on becoming pregnant, who have taken the COVID vaccine. So again, like Dr. Robinson said, we got to be nimble. Those data are evolving. I would consider ACOG to be the leading expert on this because this is what they do. And what they are saying right now is that it is safe, in fact, for pregnant and lactating women or women who are planning on becoming pregnant on getting the vaccine. Their position is also that it's better for those women to be vaccinated than it is for them to contract the virus. And so I encourage people, we've looked a lot at the CDC as a primary source of information, but there is no necessarily sole source for this. So for pregnant and lactating women or women who are planning on becoming pregnant, I do encourage them to go to the American College of Obstetricians and Gynecologists because they really are updating that information in real time as they get it. And it looks like now it is safe for pregnant and lactating women or women planning on becoming pregnant to get the vaccine.
And I'll build on Dr. Verholden's comment. Early in the pandemic, we thought that COVID illness was not more severe in women who were pregnant. But as we moved towards the end of 2020, some of the studies came out did reflect that women who were pregnant who contracted COVID actually had more severe clinical courses. And so that's definitely something to keep in mind. And I recall even running into clinicians in a clinical setting that were pregnant and they were trying to figure out whether to take the vaccine or not in the face of being actually exposed to COVID in the workplace. So definitely ACOG's recommendations and guidance, I think, is very important for consideration.
So I'm going to combine a couple of vaccine related, I have allergies like crazy. Maybe I can get the docs to prescribe something better than what I'm taking. So 2 questions. How soon after being vaccinated can I travel? And do I need to wear a mask when I dine with unvaccinated people, unvaccinated children, or vaccinated people? So this is, how do I live with this vaccine and those around me? And anyone of the panelists can answer that, I'm sure.
So the vaccine doesn't fully become operational until about 2 weeks after your last dose. And so I would not travel unnecessarily until somewhere between 9 and 14 days is what the current data shows. So to be on the safe side, I would say 2 weeks. In terms of the mask, again, as Dr. Robinson was saying earlier, there are a lot of asymptomatic people there are asymptomatic asymptomatic people who have gotten the vaccine who still can be at risk of contracting the disease and shedding the virus. So to the extent possible, you want to try to, wear masks as much as possible. Obviously, if you're actually eating, it's not, it's going to be difficult. But I think you have to use your common sense and try to be as conservative as possible in terms of putting these barriers in place.
Can I offer one other thing here, which is the concept that we don't talk enough about around social pods? Because the reality of it is, even once you get the vaccine will greatly reduce the likelihood that if you become exposed, that you would contract COVID and that you would spread COVID. If you do contract COVID after vaccination and the full benefit of it, the likelihood that you would become severely ill from it goes way, way down. But it is an imperfect layer of protection. It's not perfect. And then we've also heard about breakthrough. People who are fully vaccinated, they've waited 2 weeks after that last dose, they've got the full benefit, and they still become a breakthrough case, i.e., even something that's 95% effective. That means 5% of the time it fails, okay? And it's better if you're gonna contract COVID vaccinated than unvaccinated. So really, I think the question is, what does heightened responsibility look like? Going out to dinner or engaging in a group activity with people that you have no meeting of the minds on, you don't have established group norms, I don't think is a good idea. This is the time to start to elevate those conversations. And if people don't know, yesterday was National Healthcare Choices Day. And the push for that was for people to talk with people about their end of life wishes or advanced directives should some bad illness befall them and they lose the capacity to speak for themselves. Well, we're all living and we're all alive, and we don't know why COVID robbed some people of vitality, why some people are long COVID cases and others are not. But if you plan on having dinner with people, the thing to do is to plan for it. Let's make a dinner date that's 2 weeks out. Let's make sure that everybody in the 2 pods or the 2 or 3 families that might be coming together for dinner have some basic agreements in place, that people will practice masking up and social distancing and hand washing for the 2 periods preceding the dinner. Let's make sure that we're not bringing more than 2 or 3 families together, so that even if you're vaccinated and you choose to be unmasked in that setting, you're operating and in communion with people who have also been honoring the same basic preventive protocols. It's more than just deciding on a Friday night you want to all have dinner on Saturday and coming together. There are ways to do this responsibly, and that's what a pandemic calls for: heightened responsibility and group accountability. If people did that, that would also help, I think, to flatten the curve and give people some sense of normalcy and the ability to fellowship.
So this is a quick answer. If we know this information, what percent of the 562,000 deaths from COVID were Black?
I was trying to look that up on my phone. I don't know the exact number because that's the latest CDC statistic from today. But again, the largest racial and ethnic demographic comprised of, contributing to deaths in the U.S. is an African-American community.
Thank you.
Yeah, the only thing I could add to that is in the early stages, at least in Michigan, Blacks make up about roughly 13% of the population, and 45% of the deaths were in the Black population. Now that was in the early days of the pandemic, when there was a huge racial disparity, as was mentioned by Dr. Verhoeven, and I also mentioned it earlier. By the early summer and on through the fall, that disparity had been greatly reduced, if not actually eliminated, for new cases. So when you put all of it together, it's going to be much less cumulative than the 45%, but I don't know the exact number either.
Dr. Verhoeven, do you have that stat for Michigan?
I can tell you that African Americans are overrepresented in COVID deaths. So in Michigan, we're just over 14% of the population. Early in the pandemic, we were 41% of cases, and we were 14% of the population, and we were 41% of cases and more than 50% of the deaths. We had closed that disparities gap by September. And now what's happening is, and this is really unfortunate, I hate to say this, but we have more than half of the data that we collect on COVID cases are missing race. So I don't think anybody with certainty could say what percentage of COVID cases or COVID deaths are African American, because unfortunately there's no enforcement of the law that we report that data. And so it's a hard question to answer. But if we look at the data we do have, it looks like African Americans are about 2.5 times overrepresented relative to our representation in the population.
So I think we've answered the question about whether or not a person can contract COVID-19 more than once. But I didn't know if anyone wants to shed any light on that further.
Well, I would
would
say
just
you
add
can,
that-
you can contract it more than once. And now that we're looking at recurrent cases, earlier in the pandemic, it looked like some people were having a harder time with COVID on their second infection or reinfection. What we do see is that people, even if they're reinfection cases who are vaccinated, are doing far better with managing and recovering from COVID than people who are unvaccinated. And I don't typically tell people to get vaccinated. I'm probably going to switch that pretty soon, because I do feel like we're in a pants on fire state of emergency here. But you can be reinfected, and reinfection appears to be a lot milder, and people are better able to recover and avoid hospitalization if they're vaccinated versus unvaccinated.
I don't know, Dr. Wilson or Dr. Robinson, did you want to add to that anything?
I was just going to add that, some of the reports out of Brazil have reflected pretty high COVID infection rates there, and then a high level of recurrence of infection occurring, suggesting that the natural immunity that people gained from their initial infection was not sufficient in protecting them from some of the variants. And I know that what researchers have suggested here has been that our vaccine-induced immunity actually provides a longer level of, or a longer duration of immunity and stronger protection against the variants. So I think certainly building on what Dr. Verholden has noted, getting vaccinated is really important to also helping reduce that. And that's why there's also a recommendation for individuals who have been infected with COVID-19 to still get a COVID-19 vaccination. And I believe the recommendation is to wait a 90-day period after your period of infection is resolved before you get the vaccine. But that also is to provide that stronger duration of immunity, and also based on some of the lessons that we're learning regarding some of the shortcomings of natural immunity that we've seen in different parts of the world with COVID-19.
And if you can get reinfected, you can reinfect others. So,
yeah, and COVID is not the only disease that works that way. There are a lot of other diseases where vaccine immunity seems to last longer than the natural immunity that people develop from infection and recovery. So this is not a unique to COVID thing, that vaccine immunity sometime will last way longer than natural immunity.
yeah.
Dr. Meadows, this is Dr. Wilson. I do apologize. I've got a opposite problem with Dr. Verholden. For some reason, I didn't realize that this went on till 2 o'clock, and I scheduled a 1:30 meeting. So
Okay.
I'm going to have to leave.
Okay.
And I do apologize. I just somehow just missed me that this was not over till 2 o'clock.
No worries. We are so happy to have you for the time that we did, Dr. Wilson. Really appreciate you. I think we're in good hands with Dr. Verholden and Dr. Robinson, and we'll just move through the rest of
Okay.
these.
Well, thank you very much, and thanks for your understanding.
You do have two. You could do 1 minute. Do you have any closing remarks to share with the group in the minute that you have?
Yeah, sure. So this is what I would say, particularly, given the comments we just made about both the prevalence in deaths in African Americans. When people ask me why we were able to reduce that disparity in African Americans by, the summertime, late summer, I don't think we know for sure, but I think part of the issue was that African Americans, particularly in Detroit, personally had the COVID-19 virus hit them if not themselves personally, certainly family members, and many lost family members early on as a result, or friends, early on. And I think that African Americans in general tended to practice the public health measures with more vigilance early on than the general population because of that early experience. That's one factor. When you just kind of go around the different places around Michigan, in most African American communities that I went around, people were wearing masks, and they were scared, and they were not flaunting for political reasons or otherwise some of the measures that have been put into place. And as Dr. Verhoeven was mentioning earlier, these public health measures are extremely important, and the vaccine is just one tool in the armamentarium, but these public health measures are extremely important. And I've just got to believe that the vigilance that the African American community displayed and adhering to public health measures was very, very helpful. So I just urge everyone to continue to take this seriously, and continue to wear your masks, continue to social distance, don't take chances you don't have to take, and let's get to the back of this. Okay?
Thank you
It's been a
again,
pleasure.
Dr. Wilson. Enjoy
Okay.
the rest of your day.
Bye-bye.
Okay, we've got quite a few questions, panelists, so we're going to try to move through as many of them as possible, okay? So keep that in mind as you respond. So one of our questions is, how can we get the younger generation to get the vaccine? Many are not going to get vaccinated or are not sure about it. Any message that we can share with the younger generation beyond what we're sharing with everyone else?
I think the younger people are their best and own trusted messengers. Again, I think the push should be to make sure that everybody who wants the vaccine, that we're able to get that injection in the arm. If we just simply did that, there would be a natural social pressure and social phenomenon that would happen in peer groups and workplaces and families and places of worships where, literally there's like jokes going around. People get the vaccine and then people respond. Did you grow a third arm? Did you lose your mind? Did something bad happen? So the best messenger is the person that that you trust. And I was somebody who, when the vaccine first came out in December, somebody said, are you going to get the vaccine when it comes out immediately? And I said, no, not me. I needed to wait and see a little bit. And my wait and see was about 3 weeks. It took me about 3 weeks. Mind you, I'm in the healthcare sector, so I know a lot of people who did go first. And I was able to get those concerns remedied very early on. I think the best thing that we could do is honor all of the tremendous, bold, and courageous young people who said, I'm ready, I want it. Let's do everything we can to get the shot in their arm, and they will be the best trusted, incredible messengers for their peers.
Okay, so Dr. Robinson, I'm going to give you these next several questions. One is, what therapies will be available if I become sick in the next year after being vaccinated? And I'll just combine that with another question that says, how long are you protected after getting your second dose?
Great questions. So we know that there's a lot of innovation underway to help improve therapies that are available for treatment of COVID-19. We know we started out the beginning of the pandemic with kind of hodgepodge of guesses around what the best treatment approach would be, but also a number of studies that were done to evaluate that. And that has landed us with some specific tools or therapies that have demonstrated some effectiveness in reducing the severity of illness, the length of hospital stay for some patients with COVID. And I think we expect that armamentarium will grow and get stronger. Hard to predict exactly what that will be. So what I would do is, instead of planning to get sick in the next year with COVID, I think what we do want to do is ensure that we are vaccinated, ensure that the individuals around us are getting vaccinated, ensure that we continue to take many of the public health protective steps that we've talked about during the presentation today, until we reach a stage of herd immunity where the amount of virus circulating in our communities is sufficiently low such that our public health recommendations change the types of preventive steps that we take. But I think certainly if you're continuing to mask up, keeping some distance, and you're getting vaccinated, you've taken some really significant steps towards reducing the likelihood that you'll even get infected. And certainly by getting vaccinated, you significantly reduce the risk of severe illness from COVID and the risk of being hospitalized from COVID. So those are very important things.
So they're working on therapies, we know. The second part of that question is, once I get that vaccine, how long am I good for?
So that's something that we're still evaluating. And I think over time, we'll be able to figure that out. Again, earlier we talked about whether boosters might be needed. There's been some discussion regarding that, whether it's strengthening the duration of current immunity or adding in some elements of or characteristics of some of the variant viruses of COVID-19 to strengthen the existing protections. So I think the science will kind of lead the recommendations regarding that. I think we should just have an open mind that could be a possibility. And we're used to the fact that there are some vaccines that we get periodically, an annual flu vaccine, tetanus and diphtheria or Tdap boosters every so many years, pneumovax vaccinations. What we could even see in the future, leveraging some of the newer technology available, is perhaps the combination of some vaccines, which we typically see with some of our younger kids, that might perhaps lessen the number of different vaccines that we have to get. So we'll see what the future holds regarding that.
Thank you. Dr. Verholden, just kind of going back to the science, have you heard anything or seen anything about the side effects? The question is asking, is it typical to not have any side effects after 1 or 2 doses of the vaccine?
Yeah, this is very much, I think, in line with the same thing around when people get the virus, right? Like, it doesn't look the same for everybody. Remember, when COVID first came here, we didn't hear about loss of taste and smell. We heard about cough and throat and fever and all those other things. It was really when it hit America that we started to elevate this profile of symptoms called fatigue and body aches and some of these other things. So what I would tell people is, if you have side effects, and when I got my first dose of vaccine, it was sore at the site of injection for about 2 days. And I said, every time I touch my arm, it's sore. And my daughter looked at me and she said, well, stop touching your arm. Guess what? Problem solved. And so the side effects are normal. If you get something the normal side effects, tenderness at the injection arm, I can guarantee you, if I just took a sewing needle and stuck it in your arm, it would probably be sore for a day or two, okay? So, but if you physically cannot move your arm, if you've got a headache that makes it hard for you to focus or concentrate or get out of bed, if you're fatigued to the point that you can't move your arms and legs, that might be something more severe. That's why it's important that everybody have a primary healthcare provider. If you have side effects that are outside of what we would call the realm of normal, immediately reach out to your primary care provider. Most people who would have side effects, those side effects will show up very soon after you get the vaccine. We saw with Johnson & Johnson, some women developed blood clots. Those took a week or 2 to show up, but guess what? They had symptoms that superseded and went outside of the normal symptoms that we've talked about. So if you have any of those type of symptoms, definitely seek care from a healthcare provider. And, tenderness on the arm, being a little fatigued, a light headache, a slight fever, those are all, indications that your immune system is working. And your immune system could be working and you're getting the full benefit, and you could be somebody like me who has no symptoms. And I will tell you, after I got vaccinated, my daughter contracted COVID. She lives in the house. She has a terrible habit of drinking out of beverages in the fridge and putting them back in the fridge. We stopped doing that, and I really implored her to stop doing that. We have a little set of protocols we honor even in our house. And as a fully vaccinated person, I was in the house with somebody who had COVID and myself did not contract COVID and was her caregiver during COVID. So it is very possible to be exposed and not actually contract the virus. And you can get vaccinated, have no symptoms, or get vaccinated and get a bunch.
Thank you, Dr.
If it's too much, though, call a doctor. Do not suffer at home. I encourage people, do not suffer at home. And the last thing, and I know you saying I'm going too long, but I'd rather go deeper than just too wide. People are still getting all of the normal illnesses that we got beforehand. Let us not forget, cardiovascular disease is the #1 killer in America, and it remains the #1 killer. It robs people of life and vitality. If you have a blood clot, whether or not you got the vaccine, we've learned a lot more about symptoms of blood clots. One of the collateral impacts of COVID is people are suffering at home for fear of going and seeking care. And I'm encouraging people not to do that. Still, please continue with your primary and preventative care. And if you have symptoms, whether or not you've had the vaccine, if you have a headache that you can't shake for 2 days, you've got a severe pain in your leg, pain in your arm, a headache that won't go away, reach out to a primary healthcare provider. And if you don't have a primary health provider, reach out to your local federally qualified health center, FQHC. You can literally go online and Google FQHC and put in your county. And everywhere in Michigan, there are multiple FQHCs in most jurisdictions. Seek care. Do not let COVID let you not tend to the other conditions unrelated to COVID that are cropping up.
I want to just add a very quick comments. Dr. Verholden made some very important points around why you should seek care. So 2 things: with vaccine symptoms usually occurs more after the second shot, and usually it's 48 hours after the second shot. More individuals under the age of 65 will get greater fatigue and arm pain than individuals over the age of 65, just to kind of anticipate what you may experience. And just dipping our toe in the water on the blood clot issue concern with the J&J vaccine, Dr. Verholden made a very important point. Part of the clinical course of severe COVID illness involves a lot of thrombotic disease, a lot of blood clots, individuals having strokes and issues with their heart and other parts of their body related to clotting. So if you find yourself in a situation where you're like, I don't want to get the vaccine or any vaccine because I might get a blood clot, just keep in mind that getting COVID and getting sick with COVID, put it this way, if you had 6.5 million individuals that got COVID, more than 6 individuals with COVID had clotting diseases related to their COVID illness. So I'm not minimizing what we are exploring and understanding with the J&J vaccine, but just want to ensure that individuals understand that getting infected with COVID is not a risk-free venture that we want people to be really, really attentive to.
I have the stats from East Lansing. 16.9% of patients who are hospitalized in East Lansing develop some kind of blood clot. That would be compared to the 6 that we aren't even sure are causally linked, but let's just do that for now. Let's say the 6 out of the 6.8 million doses of Johnson & Johnson that were delivered, that would be 16.8% of hospitalized patients compared to 0.0000001% of people who got the vaccine. Like, I hate to be dramatic about it, but that is real and that is the data. And I do believe that people fundamentally should grapple. They should get their questions answered. And the other thing that I've seen is oftentimes when patients are hospitalized because of COVID or their loved ones are hospitalized, I see a lot of regret and people wish that they had made other choices on the front end. And they're not asking all the questions about the therapeutics. Nobody is asking questions about what is in monoclonal antibodies. Because guess what? If you or your loved one is hospitalized for COVID, you're going to want every therapeutic that's available for them to support their recovery in their life. So I appreciate having this conversation, and I'd rather people grapple now than be a no to something that I do ultimately in my heart and soul believe is going to be in their best interest.
Well, I didn't know that that simple question was going to yield this much wonderful information. We do have quite a few questions left, and some of which are very profound. So I hope that we'll try to keep the answers short as much as I know you want to hear. And everything that comes out of your mouth, Deborah, is valuable. So don't think that I'm discounting that. I just want to get to what our audience is concerned.
Sure, I got you.
Dr. Robinson, I'm going to give this one to you for a quick answer, and maybe there's not a quick answer. I know I had a little hesitancy around the mRNA because it was a new approach to vaccines. I mean, not new in the way that science hadn't been looking at that for a time, but The question is asking, does the mRNA vaccine cause cancer? Is fetal tissue used to make the vaccine?
To my knowledge, the mRNA vaccine has not been identified as a cancer-causing agent. I'm not aware of the fetal tissue use question regarding the vaccine. So that's my quick answer.
And I know the next question is really related to the approval of the vaccine for children. And I think it varies from state to state that it also is actually being used and considered for children. Any
So the
comments on that?
Sure. So the Pfizer vaccine was tested in their trial in individuals aged 16 and up. Moderna was tested 18 and up. And I think Johnson & Johnson was 18 and up as well. To my knowledge, Pfizer has completed its trial of the COVID-19 vaccine in children ages 12 to 15. And they're on the path towards requesting emergency use authorization, which we anticipate will occur perhaps by the fall. They're also engaged in clinical trials for the vaccine in children ages 6 months to 11 years of age. And based on the results of those trials, we may expect some potential authorization in early 2022. I don't have the stats on the Moderna trial in children, although I'm aware that there is some activity there. And then keep in mind that there are a number of vaccines under development around the world outside of the United States that may also have trials in different age groups.
Okay. Dr. Verholden, any research that you know of on this, or anything you've been hearing around vaccines in children?
No, just what Dr. Robinson said. And I'm super excited that they're doing the vaccine testing in children. They just started a trial at Stanford 2 days ago in children 2 years and up. So we're gonna be learning in real time what those results are.
This is from Dr. Robinson. I'll let you start with this one. One of our participants said, I had a blood transfusion in '78 after childbirth and was told I had blood antibodies. Is that a concern for getting the vaccine?
Quick answer is no.
Okay. So Deborah, this sounds like one for you. How can we as ambassadors in our community get the message out better and address misinformation? I know you've partially answered that, so maybe anything that you would add beyond what you've talked about, and trusted messengers, family members who received it, people that you trust who've received the vaccine, anything else you would add to that?
I think lived experience will go a long way here. People getting vaccinated and being able to share about their experience with people, saying, I had a sore arm, I took I'm sorry, I've been told not to use a brand. I took an acetaminophen or an ibuprofen, and my grandfather called our refrigerator the Frigidaire. So I just,
You got to say what people know.
I know. So taking a Tylenol or an Advil or an ibuprofen or whatever, I think that will go miles. And then the other thing I want to point to for folks, both leaders of this church and people, no matter where they are, it's raining COVID dollars in the world right now. The relief package is $1.9 trillion. A lot of that money is being earmarked in ways that the CARES Act money was not earmarked. So there is also a lot of resource that's available for grassroots community organizations, community partners, and other organizations to not only join the fight, because many of them are already in the fight, but to actually have the resources to be able to do that. So I would say your lived experience is the best, and do keep a watchful eye to what funding opportunities are available for your churches and community organizations and local health departments to be better resourced to do the kind of information dissemination that will be needed.
Okay, we got a lot more questions than we have time, so I'm going to see if I can combine a couple and get my panelists to do quick answers. So
Okay.
I don't know if you know this one, Dr. Verholden, whether or not MSU and Wayne State, I know Dr. Wilson just left, are going to require vaccinations in order for students to attend class in person.
I can't say with certainty whether or not it will be a requirement. What I can tell you is both universities have robust testing systems in place, both for students, staff, and faculty, to ensure protection of all of the campus stakeholders and the communities where they reside. Whether or not it will be required remains to be seen.
Okay. Dr. Robinson, this is a quick one for you too. And I'm going to take a little creative license with the wording. And is one or either of the vaccines more, or should I say one or more of the vaccine, one each of, okay, maybe I shouldn't take creative license. So I think the point is, if you have an underlying health condition, is there one vaccine that you should take over the other?
You know, I don't think that's the predominant recommendation at this time. I think we're recommending that individuals get whichever vaccine they can get as fast as they can, so that we reduce the window of time that they have exposure and that they're not vaccinated. Having read the FDA materials that were reviewed for approval for both Pfizer and for Moderna, I know that they looked at not only different age bands, not only racial and ethnic categories, but they also looked at different condition categories. So they were able to count the number of individuals who had diabetes, or who were obese, or who had asthma, or who had immune disorder, or who had issues with their kidney function and other chronic diseases, so that they could present data regarding the effectiveness of the vaccine in those different condition categories.
So you partially answered this question from one of the participants. It says, if you're trying to get your diabetes under control, should you take the vaccine?
Well, I would say that the vaccine itself probably doesn't assist you in getting your diabetes under control. But what we do know is that individuals who live with diabetes, who become infected with COVID-19, have higher hospital complications and higher death rates than individuals who do not. So it's in our best interest to do a couple of things. One, ensure that we all get vaccinated. Two, if you have a chronic medical condition like diabetes, get vaccinated. And three, do your best to keep those chronic medical conditions under control so that they're not raging and kind of running high, is what I would say.
And that's existing and emerging, right? Because the stress and trauma and all that comes with weathering the storm of a pandemic, you will see new onset of diabetes and cardiovascular disease and all of that. So literally people still continue with your primary and preventive care, manage ongoing chronic conditions, and be on the lookout for new and emerging ones. I just really consider this an opportunity for us to take the reins of our own health. I tell people, you are the captain of your health team. Your physician is the equivalent. I'm bad with sports analogies, but let's call that the forward on your health team. It is a primary care provider is an important member of that health team. So it's important that people manage existing chronic health conditions and also monitor new ones. Something that we haven't talked about is there's been an uptick in undiagnosed breast cancer. We've got some new emerging data around that. Why? Because we saw mammography drop down during COVID. People are still developing breast cancer. The fact that you're not getting it screened and detected and identified doesn't mean that it's not happening. So please, please, please continue with all of your primary care and your preventive screenings. Colorectal cancer, breast cancer. We've seen increases in obesity during COVID. The other COVID-19, the extra weight we've all gained, sitting on our behinds and not going out as much. So please continue to monitor and practice good primary and preventive care.
Okay. Well, these are a quick medical question related to immunity. Can checking serum antibody levels show you your immunity or antibodies?
If the question is related to following getting vaccinated, I don't think it's recommended that you get a serum antibody test to confirm the validation of the vaccine. Individuals who have been infected with COVID before, you can get both the PCR test to test for COVID, and you can also get a serum antibody test to see if you've been exposed to it in the past. I don't think that there's good reliability that that's going to provide you with immunity going forward. So I think there's still recommendations that individuals get vaccinated.
Yeah, if I could add one more thing,
Dr. Verholden, we're going to be wrapping up, so I'm going to let you do that. Give
Okay.
you your 3 minutes to wrap up. We've got 8 minutes to go, 3 minutes from you, and if we can get 3 minutes from Dr. Robinson to say those things. We didn't get through all of these questions, but we covered them in part throughout the conversation today. So your last 3 minutes, what would you have to say to the audience?
So I'll say that the serum antibody testing is really good for us understanding how many people in our community have been potentially exposed to the virus. It's not the best measure of whether or not you as an individual are protected. So even if you get a positive serum antibody test, it doesn't mean that you won't benefit from the vaccine. So again, I'm going to point back to, this is a time now more than ever to really underscore the need for primary and preventative care. I think everybody needs access to a primary care provider. If people didn't know, enrollment reopened for the Affordable Care Act. There are all kinds of rebates and discounts. If you are at 400% of the federal poverty level, 400%. So what we used to call poor, you can be at 400% times that income, and your health care could cost you as little as $10 a month right now. I'm encouraging people, if you don't have a primary care physician, get one. If you don't know how, start with your local federally qualified health center. Be the captain of your own health team. Be listening to your body. The 3 recommendations that I give to people to do your best around, besides getting vaccinated and honoring the protocols, those are my first 2. Get your vaccine. And the best vaccine for you to get is the one that's available to you. What you can trust is that if a vaccine has any indication that it might not be safe, or we might need to identify people at excess risk for a poor outcome or an adverse reaction, we will do exactly what we did with Johnson & Johnson, and we'll just temporarily hit the pause button. And I'm not saying that Johnson & Johnson is not safe. We just have to pause for a second and make sure that if some people are at elevated risk for a blood clot, we know who those people are so they won't get that particular vaccine. So honor the protocols, get your vaccine. The other 3 things for people: practice good sleep hygiene. Sleep is restorative. It is your body's way of repairing, healing, and restoring itself. Practice good sleep hygiene. 2, eat the highest nutrient-dense diet that you can afford. Nutrient-dense foods tend to be the ones that don't have a label on them. If you reading the label and you're seeing all the calories and the fat and the salt and all that, chances are those are not the kind of foods that are going to boost your immune system and keep you fit for the fight called life. And then the third thing is move your arms and legs every day for 30 minutes. If you can, walk in your neighborhood. I'm not going to the gym. I haven't been to the gym all of COVID. So I tell people I mop like nobody's watching. I fold laundry like I was in a dance-off with Janet Jackson herself. I just intentionally and mindfully practice moving my arms and legs 30 minutes every day. So sleep, eat the best nutrient diet you can afford, move your arms and legs 30 minutes every day. Practice good primary care and honor the protocols. Practice good COVID prevention and get your vaccine.
Okay. So we have 4 minutes to go. Dr. Robinson, Deborah took 2 of your minutes. I'm sorry.
Hey, it's all good. It's all good.
But I know we needed to hear that. We want to have a closing from the pastor. So if we can hear any closing thoughts that you didn't get a chance to say that you want to be able to say.
Absolutely. So first, Dr. Meadows, thank you for being a great moderator. It's been a pleasure to be on the panel with Dr. Wilson, Dr. Verholden, who's given some great nuggets there that we all need. And we also need to hear a word from the Lord as well. So I will not be long. But these certainly have been very challenging times for us. I'm grateful to have had this opportunity to participate in this dialogue and answer questions with members of the community regarding their concerns with COVID-19. It's been challenging for me professionally and personally. I've suffered losses in my family, both from COVID-19 as well as breast cancer and many of the other conditions that continue to plague our communities. And keep in mind, we were dealing with significant epidemics within our community before COVID-19 came on top of it. The path forward is going to be really important for us. We need to move collectively together towards better health, surviving through the pandemic, but also ensuring that we're positioning ourselves to thrive on the back end of it, thriving spiritually, thriving physically, thriving economically. And so I hope that the information that's been shared today helps contribute to our individual and collective journeys in that regard. So thank you all so much for the opportunity. And I'll turn it back over to you, Dr. Meadows.
Well, thank you both, and to Dr. Wilson. It's been amazing to be somewhat of a moderator. You didn't need me because you're handling this just amazingly. So much wealth of information. It's been a pleasure. Just enjoyed being a part of such great experts. You've gotten all kinds of shout outs in the chats if I haven't given them to you. But with that, I don't think I need to say anything more than just thank you, God bless you. And I want to turn it over to Pastor Smalls to kind of close us out.
Thank you very much, Ms. Meadows, and to this extraordinary doctoral team that has been present today. We are grateful very much for all that they have shared and for this dialogue. I continue to suggest from a religious perspective that one of the greatest pandemics that we are wrestling with is that of ignorance. And just the other day, there was an article from one of the major networks highlighting a pastor that was urging his congregation to not take the vaccine because of extraordinary distrust of the government, and medical community, and all that. And I just want to remind us that medicine is not antithetical to faith and theology. In fact, the Gospel of Luke was very much written by a physician. And God employs many different resources for us to reach optimal health, optimal life. And the goal, of course, in faith really is to be as optimal as we can be individually so that we can increase our witness and impact and transform the world for the good. So I thank you all for this conversation, and I thank our United Methodist men for the vision and for the dialogue. This is right up Hope's alley. Hope has always been a congregation that has sought this type of dialogue and this kind of conversation. So I am grateful for it. And I will pause to offer God's blessing, and we can move forward from there. Thank you all again. Lord, for today, we give you thanks. We thank you for the gift of conversation. We thank you for the gift of these presenters who have led from the best of places in which this kind of work is employed and distributed and experienced. And so we thank you for the gift of their presence and the gift of their knowledge and insight. Thank you for these who are here, and we continue to strive to be your people in the world. And we thank you for a vaccine. We thank you for 3 companies that have provided one. And we continue to pray total health and healing among all those that are seeking it, among all those that are attempting to maintain it, so that we may indeed be the best we can be. And it is in the spirit of your resurrected Christ, our Lord, that we do pray and offer one another his love and peace. In Jesus' name, amen. Thank you all. I'm grateful for you.
Thank you, Pastor. Are we going to do the after service fellowship? You know, because after service, people just hang around and fellowship a little bit longer.
Well, see, we would have, but you know, we had the cookies and the punch knowing y'all were coming, so.
We can have some virtual cookies. You touched on one thing, and I know the formal part is over, but I do want to say one thing because it's burning on my spirit to say it, which is that this has taken a tremendous toll on people mentally and physically, this pandemic. And faith is a powerful, powerful thing. But my experience is if I encountered somebody who had a broken leg and they had a bone sticking out of their leg, I wouldn't ask them to pray about it. I would tell them to go to the hospital. And the greatest physician of all, we know who that is. We know God is the master physician and healer. But I wouldn't ask somebody to suck it up and buck up and pray on the healing over their broken leg. And I just don't want us to be that way about people's broken spirits or their broken minds or their broken hearts because of the season that we're in. So I do just implore everybody to practice more kindness and empathy and be paying attention. Because while faith is a powerful thing, God has placed some very critical people and resources in our lives. And I just don't want people to see them as in opposition. They're not. If you had a broken leg, you would encourage somebody to get that broken leg healed. If you encounter somebody who's struggling with, we don't talk about it. We've had so many suicides, excess suicides and mass shootings that have happened during this season because people's minds and spirits are broken. So let's just encourage the same healing, and our faith will support us and sustain us. But we also need to encourage people where needed to get care for those things as well.
Absolutely.